Most people, when they hear the word dementia, think of one thing: memory loss, Alzheimer's, an elderly person who forgets names and faces. That understanding is incomplete, and in some cases, dangerously so. There are more than 100 distinct medical conditions that produce dementia symptoms. Most of them are rare, but the 6 most important ones, the 6 that account for the overwhelming majority of diagnoses, are what most families never fully understand. Not because the information does not exist, because nobody has time to explain it clearly. When a family receives a dementia diagnosis, they are told the type, and then the appointment ends. The word vascular or Lewy body or frontotemporal goes home with them in a pamphlet they may not read for weeks. And they spend the coming months trying to understand what they are actually dealing with. Today, I am walking through all 6. What causes each type? What makes it different from the others? Who it affects? What symptoms it produces? And, most importantly, why the specific type matters for the care and safety of the person who has it. The type of dementia matters clinically, not just for academic reasons. Certain antipsychotic medications that are sometimes prescribed for behavioral symptoms in dementia can cause severe, life-threatening reactions in people with one specific type. If the type is not correctly identified, or if the medical team is not informed of it, medication that was intended to help can cause serious harm. Frontotemporal dementia produces behavioral changes that are often misdiagnosed as psychiatric illness. The average time between first symptoms and correct neurological diagnosis is 3.5 years. During those years, people are sometimes treated for depression or personality disorders, while the neurological disease progresses untreated. Vascular dementia responds to a completely different prevention strategy from Alzheimer's. Mixed dementia, which affects nearly half of all people over 80 with dementia, is routinely undiagnosed. Getting the type wrong does not just delay treatment, it can actively affect the safety, dignity, and well-being of the person who has it. Subscribe now and help Dr. Mannu Jones reach the families who need this. The most harmful misconception about dementia is that it is one disease with one set of symptoms that progresses in one direction. It is not. Alzheimer's disease starts in the hippocampus and slowly steals memory before any other function. Frontotemporal dementia starts in the frontal lobe and changes personality and behavior while leaving memory largely intact for years. Vascular dementia does not progress gradually, it moves in steps, with periods of stability interrupted by sudden drops after vascular events. The symptoms look different. The affected brain regions are different. The cause is different. The rate of progression is different. And in several types, the treatment approach is different in ways that matter significantly for the person's quality of life. Understanding the specific type is not a detail for specialists. It is the foundation for everything that follows: how to communicate with the person, what medications are appropriate or dangerous, what the trajectory looks like, and what to prepare for. Here is what you will leave this video knowing: the 6 most important types of dementia, their cause, their primary affected brain region, their distinguishing symptoms, and the critical information most families never receive. I am also going to address both audiences watching this. If you are watching this for yourself, perhaps because you are experiencing memory or behavioral changes and want to understand what different diagnoses mean, this video gives you the language to have a more informed conversation with a specialist. If you are watching this for someone you love, a parent, a partner, a person whose diagnosis you are trying to understand, this is the framework that will help you make sense of what you are seeing and what to expect. Let us start at type 1, the most common type, the one most people think is the only type, and the one all others will be compared against. Type 1, Alzheimer's disease. Between 60 and 80% of all dementia diagnoses. By far the most common type, the benchmark against which all other types are measured. Alzheimer's disease is caused by 2 abnormal proteins accumulating in the brain. The first is beta amyloid, which clumps between neurons forming plaques that disrupt communication between brain cells. The second is tau, which becomes misfolded inside neurons, collapsing the internal transport system that keeps neurons alive. As neurons die, the brain shrinks measurably, beginning in the hippocampus. The hippocampus is the brain's recording center. It forms new memories before they are stored elsewhere. When Alzheimer's attacks the hippocampus first, the result is a specific and consistent early symptom pattern: difficulty remembering recent events. Not old memories, those are stored elsewhere and remain accessible for years. Recent memories, a conversation from that morning, the name just introduced, the appointment made yesterday. This is why someone in early Alzheimer's can describe their wedding in vivid detail, but cannot recall what they had for breakfast. The archive is intact. The recording system is failing. As Alzheimer's progresses outward from the hippocampus, it affects language, then reasoning and executive function, then personality and behavior, then physical function. The progression is gradual and continuous, not sudden or stepped. This distinguishes it from several of the types that follow. The most important single fact about Alzheimer's disease is one we have covered in previous videos on this channel. The biological process begins approximately 25 years before the first symptom appears. By the time of diagnosis, significant damage has already occurred. The window for lifestyle-based intervention is not after the diagnosis. It is now, in the decades before symptoms emerge. For yourself, if you or someone you know has received an Alzheimer's diagnosis, understand that it is the most common type, which means it has the most established treatment approaches and the largest body of prevention research. The 2024 Lancet Commission identified 14 modifiable risk factors that influence Alzheimer's risk. Nearly half of all cases are potentially connected to factors within our control. For a loved one, the gradual nature of Alzheimer's means years of functional capacity remain after diagnosis. The decisions and conversations that matter most, advanced directives, financial planning, care preferences, should happen early, while participation is fully possible. Alzheimer's is the most common type. The second most common is also the most directly preventable, because it shares its root causes with the same conditions that cause heart attacks and strokes. Type 2. Vascular dementia. The second most common type of dementia, accounting for approximately 10 to 20% of diagnoses, and the one most directly connected to the choices people make about blood pressure, blood sugar, and cardiovascular health across a lifetime. Vascular dementia is caused by reduced blood flow to the brain. When blood vessels supplying brain tissue are damaged, through stroke, through a series of small strokes called transient ischemic attacks, or through the gradual narrowing and hardening of small vessels deep in the brain, neurons are deprived of oxygen and fuel. They die, and the function they supported is lost. There are two main presentations of vascular dementia, and they look different. The first is post-stroke dementia. Following a significant stroke, cognitive changes may appear suddenly. The person wakes from the stroke event and something is different. Processing speed, attention, judgment, language, depending on which region was affected. This presentation is immediately recognizable as connected to the stroke event. The second is small vessel disease. This is more insidious. Tiny blood vessels throughout the brain's white matter, the connections between regions, gradually narrow and fail. The decline is not triggered by a single visible event. It progresses in steps, periods of relative stability, followed by sudden drops when another small vessel is lost. The stepwise pattern is the hallmark that distinguishes vascular dementia from Alzheimer's gradual, continuous decline. The symptoms of vascular dementia also differ from Alzheimer's in an important way. Memory is often less severely affected in the early stages. Instead, what the person notices first, and what those around them notice, is slowed thinking, difficulty planning multi-step tasks, problems with attention and concentration, and emotional changes including depression and apathy. Do not let the relative preservation of memory fool you into thinking the disease is milder than Alzheimer's. Vascular dementia causes significant disability, and its stepwise nature means that each vascular event can produce rapid and sometimes dramatic change. The critical clinical point about vascular dementia: it is the most preventable type because its risk factors are the same as cardiovascular disease. High blood pressure in midlife is the single strongest modifiable risk factor. Diabetes, smoking, obesity, high cholesterol, physical inactivity, the same interventions that protect the heart protect the brain from vascular dementia. For a loved one, if someone you know has had a stroke and is now experiencing cognitive changes, ask specifically about vascular dementia evaluation. It is commonly underdiagnosed following stroke because rehabilitation focuses on physical recovery. The cognitive dimension deserves equal attention. Vascular dementia results from blood vessels failing the brain. The third type results from the brain's own proteins turning toxic inside neurons, and it produces symptoms that, without understanding the neuroscience behind them, can seem almost impossible to believe. Type 3. Lewy body dementia. Accounting for approximately 15% of dementia diagnoses and likely more, because it is one of the most consistently underdiagnosed types in clinical practice. Lewy body dementia is caused by abnormal deposits of a protein called alpha-synuclein forming inside neurons. These deposits are called Lewy bodies, named after the physician who first described them. As they accumulate throughout the brain, they disrupt the function of the neurons they inhabit. What makes Lewy body dementia distinct from every other type is its clinical presentation. 3 features that appear together and, in combination, are highly characteristic of this specific diagnosis. The first feature is visual hallucinations. Not vague perceptual disturbances, specific, well-formed, detailed visual experiences. The person sees people who are not in the room, animals in the house that are not there, strangers standing in the corner, children playing in the garden. These hallucinations are not frightening in all cases, though they certainly can be. What is medically significant is their character. They are visual, they are specific, and they are recurrent. The second feature is fluctuating cognition. The person can be clear, lucid, and oriented in the morning, and profoundly confused and disoriented by the afternoon. These fluctuations are more extreme than anything typical in Alzheimer's disease. A good hour can follow a very bad hour. A clear day can follow 3 confusing ones. Families often report that the unpredictability, one of the most exhausting features of caring for someone with Lewy body dementia. The third feature is Parkinsonism, movement characteristics similar to Parkinson's disease. Rigidity in the limbs, slowed movement, shuffling gait, sometimes a tremor. These motor features may appear before or after cognitive symptoms. There is a fourth feature worth knowing, REM sleep behavior disorder. In normal REM sleep, the body is temporarily paralyzed while the mind dreams. In REM sleep behavior disorder, this paralysis fails. The person physically acts out their dreams, talking, shouting, striking out, falling out of bed. This symptom can appear years before any cognitive or motor features of Lewy body dementia. If a family member is consistently and physically acting out their dreams, this is worth discussing with a neurologist. Now I need to tell you something that may be the most important single piece of medical information in this entire video. Certain antipsychotic medications sometimes prescribed to manage behavioral or psychiatric symptoms in dementia, can cause severe, life-threatening reactions in people with Lewy body dementia. This reaction, called neuroleptic sensitivity, can cause sudden and extreme worsening of Parkinsonism, profound sedation, confusion, and in serious cases, irreversible decline or death. The medications most associated with this risk include haloperidol and other typical antipsychotics, as well as some atypical antipsychotics. Even at low doses, the reaction can be severe. Clozapine and quetiapine are generally considered lower-risk alternatives when medication is genuinely necessary, but this decision must always involve a specialist. If someone you know or love has a diagnosis of Lewy body dementia, or is suspected to have it, every medical professional involved in their care must be informed of this diagnosis before any antipsychotic medication is considered. This is not a preference, it is a safety requirement. The average time to correct diagnosis of Lewy body dementia is 18 months. Many people with this type are first diagnosed with Alzheimer's disease and placed on medications that do not address the specific features of their condition. If you believe a diagnosis may not be accurate, particularly if visual hallucinations, significant cognitive fluctuation, or movement features are present, request a referral to a specialist with experience in Lewy body dementia. Lewy body dementia places abnormal proteins throughout the brain. The fourth type on this list also begins with abnormal protein accumulation, but targets the frontal lobe specifically and changes who a person is before it changes what they remember. Type 4. Frontotemporal dementia. Frontotemporal dementia differs from every other type on this list in one fundamental and often confusing way. It is not primarily a memory disease. In the early stages of frontotemporal dementia, which can last for years, memory is largely intact. The person can tell you what they had for breakfast, what year they were born, the names of their grandchildren. What they cannot do is the same as they once were. Frontotemporal dementia attacks the frontal and temporal lobes, the regions governing personality, behavior, empathy, social judgment, language, and decision-making. As these regions are damaged, the person changes in ways that can be profoundly distressing for everyone who knows them. There are 3 main variants of frontotemporal dementia. The behavioral variant is the most common and the most emotionally challenging for families. The person becomes socially inappropriate in ways they would never have tolerated before. They make rude or offensive comments without apparent awareness. They lose the ability to feel empathy for others' distress. They behave impulsively, making financial decisions that are completely out of character, engaging in repetitive behaviors, overeating, or in some cases, shoplifting or other socially transgressive acts without understanding why it is wrong. The person is not making a choice to be this way. The part of their brain that governs social awareness, empathy, and impulse control is being destroyed. The behavior is a neurological symptom, not a character problem, not a moral failure, not a choice. This distinction matters enormously for how families and caregivers understand and respond to what they are witnessing. The semantic variant affects the meaning of words and concepts. The person can speak fluently, but gradually loses the ability to understand or produce the meaning of words. Not just word-finding difficulty, but a fundamental loss of what words represent. The non-fluent variant affects speech production. The person knows what they want to say, but cannot produce the words smoothly. Speech becomes effortful, fragmented, and slow. Frontotemporal dementia is the most frequently misdiagnosed type on this list. Research has found an average delay of 3.5 years between first symptoms and correct neurological diagnosis. During those years, people are commonly diagnosed with depression, bipolar disorder, personality disorder, or midlife crisis. The neurological disease progresses while treatment targets the wrong problem entirely. Frontotemporal dementia is also more strongly heritable than Alzheimer's disease. Approximately 40% of cases have a clear family history, and it is significantly more common in younger people. The average age of onset is between 45 and 65. It is one of the most common causes of early onset dementia in adults under 65. For a loved one watching this, if a parent or partner has been showing significant personality changes, loss of empathy, social inappropriateness, impulsive behavior, or changes in their relationship to language, and memory appears relatively preserved, please discuss frontotemporal dementia specifically with a neurologist. The behavioral changes are real, the person is not choosing them, and the diagnosis matters for what happens next. Frontotemporal dementia changes the person before it changes the memory. The fifth type on this list is not one disease. It is what happens when more than one of these processes occurs in the same brain simultaneously, and it affects far more people than the diagnosis rates suggest. Type 5, mixed dementia. Mixed dementia may be the most common type that most people have never heard of, and the one most consistently absent from conversations about dementia diagnosis. Mixed dementia means exactly what it says. More than one type of dementia pathology occurring in the same brain at the same time. The most common combination is Alzheimer's disease and vascular dementia occurring together. But combinations can also include Lewy body pathology, alongside Alzheimer's, or all three types simultaneously. In 2007, researchers at Rush University Medical Center published a landmark study in the Annals of Neurology, examining the brain tissue of people who had been diagnosed with dementia during their lifetimes. At autopsy, nearly half of those over 80, approximately 45 to 50%, showed the pathological hallmarks of more than one type of dementia. Not one type that looked like another. Multiple distinct pathological processes occurring together in the same brain. This means that many people currently diagnosed with Alzheimer's disease or vascular dementia as a single diagnosis are living with mixed dementia. The dominant pathology shapes the clinical picture, which is why the diagnosis fits, but the underlying biology is more complex. Why does this matter clinically? Because each component of mixed dementia may respond to different approaches. The vascular component of mixed dementia responds to cardiovascular risk factor management, blood pressure control, blood sugar management, physical activity. Addressing these factors may slow the vascular component of the disease, even when the Alzheimer's component cannot be similarly modified. Treating mixed dementia as though it were purely one type risks under-addressing the component that is most responsive to intervention. Mixed dementia is also typically more rapid in its progression than either Alzheimer's or vascular dementia alone, because two separate processes of neuronal damage are occurring simultaneously. For a loved one, if someone you care for has a diagnosis of Alzheimer's disease and is also known to have cardiovascular risk factors, high blood pressure, a history of stroke or TIA, diabetes, or significant white matter changes on brain imaging, ask the treating physician specifically about the possibility of mixed dementia and what that would mean for the management approach. Mixed dementia is the most common type most people have never heard of. The sixth and final type carries a specific misconception that leaves families completely unprepared for what is coming because it shares a name with a disease most people think they already understand. Type 6. Parkinson's disease dementia. Most people know Parkinson's disease as a movement disorder: the tremor, the rigidity, the shuffling walk, the softened voice. These are the features that define Parkinson's disease in public understanding. What is not widely known, and what represents one of the most significant gaps in how Parkinson's disease is explained to patients and families, is this. Between 50 and 80% of people with Parkinson's disease will develop dementia during the course of their illness. More than half. In some studies, closer to 80%. This is not a rare complication. It is a common trajectory. And the families of people with Parkinson's disease are frequently not told this clearly at the time of diagnosis, which means they encounter the cognitive changes without preparation, often years into the disease when they had believed they were managing the condition successfully. Parkinson's disease dementia develops when the same alpha-synuclein protein deposits that cause motor symptoms in Parkinson's disease spread through the brain more widely, affecting regions beyond the motor system. The pathology is closely related to Lewy body dementia. Both involve alpha-synuclein accumulation. The primary clinical distinction is timing. If cognitive symptoms emerge within 1 year of motor symptoms beginning, the diagnosis is Lewy body dementia. If cognitive symptoms develop more than 1 year after motor symptoms are established, the diagnosis is Parkinson's disease dementia. The underlying brain changes are essentially the same. The distinction is largely about when each set of symptoms appears in the sequence. The cognitive profile of Parkinson's disease dementia typically affects attention, visuospatial skills, and memory, rather than the personality and language changes of frontotemporal dementia. Hallucinations can also occur, as with Lewy body dementia, for the same underlying reasons. The management of Parkinson's disease dementia is complex because the medications used to manage Parkinson's motor symptoms and the approaches appropriate for dementia can interact in challenging ways. This requires specialist coordination, ideally between a movement disorder neurologist and a clinician experienced in dementia care. The antipsychotic sensitivity warning that applies to Lewy body dementia applies equally here for the same reasons. The same proteins are involved, the same medication risks apply. Any medical team managing behavioral symptoms in someone with Parkinson's disease dementia must be aware of this risk. For a loved one, if someone you care for has Parkinson's disease and is now beginning to show cognitive changes, even subtle ones, this is the expected and documented trajectory for a significant percentage of people with Parkinson's. It does not represent a separate illness arriving unexpectedly. It represents the progression of the underlying disease. Asking for a formal cognitive assessment and a care plan that accounts for both the motor and cognitive dimensions of Parkinson's disease is entirely appropriate and necessary. 6 types, different causes, different affected brain regions, different symptom patterns, different trajectories, and in several cases, different and significant implications for the safety of the person who has the diagnosis. Let me leave you with the 3 most important distinctions to carry with you. First, if someone has been diagnosed with dementia and is prescribed any medication for behavioral or psychiatric symptoms, and if there is any possibility of Lewy body dementia, either through a formal diagnosis or through the presence of visual hallucinations, significant cognitive fluctuation, or movement features, the prescribing physician must be informed before antipsychotic medication is started. This is a safety issue. Second, vascular dementia is the most preventable type on this list, and its risk factors are the same as heart disease. Blood pressure management, blood sugar control, physical activity, and not smoking are the interventions with the strongest evidence for reducing vascular dementia risk. If someone in your life has been told they have vascular dementia or are at risk for it, these are not vague lifestyle suggestions. They are the most specific and evidence-based interventions available. Third, if a person is showing significant personality changes, loss of empathy, social inappropriateness, impulsive behavior, while memory appears relatively preserved, please ask specifically about frontotemporal dementia. The delay to correct diagnosis for this type averages 3.5 years, and that delay has real consequences for the person and family going through it. Of the 6 types on this list, 2 account for the vast majority of cases worldwide: Alzheimer's disease and vascular dementia, and both respond to the same set of lifestyle modifications. The 2024 Lancet Commission concluded that approximately 45% of all dementia cases are potentially preventable by addressing 14 specific modifiable risk factors: sleep quality, blood pressure management, physical activity, blood sugar control, hearing health, social connection. These are the factors with the strongest evidence base for protecting the brain across its most vulnerable decades. 6 types of dementia, many of them with roots in processes that begin long before any symptom appears. Most of them with at least some component that responds to what you do now in the years before a diagnosis arrives. That is why this channel exists. Not to describe what has already happened, but to give you the information to influence what happens next. One question in the comments: which of these 6 types did you know least about before this video? Just the number, type 1 through type 6. I read every comment, and your answers shape what I cover in depth next. If this gave someone in your life a clearer understanding of a diagnosis they received, share this video with them, with their family, with their care team. The type of dementia matters. This conversation is worth having. Dr. Mannu Jones is an AI-assisted health educator. Every claim in this video traces to published, peer-reviewed medical sources: the Alzheimer's Association 2025 Facts and Figures, McKeith et al. Diagnostic Criteria for Lewy Body Dementia, Raskowski et al. Criteria for Frontotemporal Dementia, Schneider et al. On Mixed Dementia Prevalence, and the 2024 Lancet Commission. These are sources you can look up and verify. This is educational content, not a substitute for specialist medical advice. If you believe someone's diagnosis may need review, or if there are safety concerns about current medications, please discuss them with a qualified neurologist or geriatrician who can evaluate the specific individual.